All right, hi. I started life as an obstetrician gynecologist, so I like to think of myself as an expert in making healthy people sick. And for those of you who don't know, we habitually make healthy people sick. For example, can you imagine any other field that could make 1/3 of healthy pregnant people require major abdominal surgery to have a baby? Well, that's us. So I have to tell you a little story about the National Women's Health Network and their book. I brought my copy. Now my copy actually was inscribed by Cindy Pearson, dated March of 2002. At the time, I was practicing OBGYN. I was fully indoctrinated with the importance of getting women at any age after menopause, particularly older women, on hormones to prevent heart disease. So certainly I was a prime target of this kind of information. Now, Adrian, who had been a medical student at Georgetown, was a student of mine when I was at Columbia Hospital, said, read this book. Adrian, by the way, is one of the authors. Cindy's an author. Charlia Mashin, who was here yesterday. You're here today, Charlia? There she is.
And Jane Jones.
Got 4 authors here.
Okay, there are 4 authors and they're here. So, in any case, Adrian said, read this book, and of course, at the time, I did exactly what Adrian told me to do it, and have been ever since. And I was blown away, because this challenged what I have been taught for forever about the importance of treating women with hormones in order to prevent heart disease. And I was explicitly told that women in their 70s and 80s should not be denied the benefit of hormones. So it's kind of amazing when I see people complaining that the WHI treated women who were too old, because they were treating, WHI included exactly the women that I was told I needed to treat for public health purposes. Well, at the time I was full-time faculty at Georgetown University, and I started talking at our department meetings about this incredible, novel, sort of crazy idea that you ought to find out if something works before you put it into widespread use. My colleagues were used to me saying outrageous things, and so they would nod politely. But then, when the Women's Health Initiative came out later in that same year, they all thought I was a genius. So I did not tell them that, no, they were mistaken. The geniuses were the ones who had written the book. All right, so here's my disclosure. I was the bone mineral density doctor at Georgetown University for many years. My predecessor was Jim Simon, who is and remains one of the major opponents of the conclusions of the Women's Health Initiative. And we won't talk about Jim and his motivations, but in any case, he left Georgetown. I inherited the directorship of the Bone Mineral Density Unit, and proceeded to do all sorts of very vile things to women who were normal and healthy and came in because their healthcare providers said they needed a bone mineral density. I also have worked for a lot of pharmaceutical companies as a consultant with regard to reproductive toxicology. These are the ones I could remember, but I have no doubt that any major drug company with any interest in reproductive toxicology gave me money for one thing or another. So what's the myth that I'm here to talk about? Certainly not that menopause doesn't exist. We know it exists, but the myth, as we all know, is that menopause is not a disease. And it looks to me like about half of you know it from personal experience, and the rest of you will know it before very long, because menopause is a condition of healthy young women. If you don't believe that 50 is young, you soon will. And this is an advertising piece that I borrowed. I don't even remember what product this was meant to sell, but clearly the message here is that one of these people is a vigorous, vital, functional young woman, and the other is decrepit, right? That says decrepit. Well, of course, this is the wrong message because, of course, women who are menopausal are not decrepit. Men like me who are andropausal, which of course doesn't exist, are not decrepit, although we have other failings. This is another advertising piece, which was meant to show that over time, this date on the bottom, the age at which women die, the life expectancy has gone up, and the average age of menopause has stayed about the same. But look how much of a woman's life is spent being menopausal. Surely these women deserve our help. Well, this is a trick question, and of course everybody here will get it right. What hormones are abnormal in menopause? And the answer is they're all normal. So the typical estradiol concentration in a woman who's regularly menstruating is somewhere between 200 and 400 picograms per ml in blood, and that's normal. But if an 80-year-old woman came in with a blood estradiol concentration of 200 to 400 picograms per ml, we would work her up for her ovarian or adrenal tumor because that's abnormal. Whereas her estradiol level of 20 to 40 or something like that is normal. And of course, I don't think I have any trouble selling that to this audience, but it's amazing how many medical student and especially resident audiences find it rather surprising that menopausal women are not estrogen deficient. They have normal concentrations of estrogens in their blood. Another advertising piece, this shows sort of schematically blood concentrations of estrogens, showing that after the menopausal transition, the estrogen concentrations shoot way down. They don't quite go to zero, but they go down much lower than they were. And you see this red outline, which is sort of like we have to do something about this. But I added to this slide, I embellished it a little by putting a similar red bar over on that left side. And nobody's saying, oh my gosh, these prepubertal girls are estrogen deficient. We need to do something about this. And of course, all of these individuals have normal levels of estrogen. This is normal. Well, if menopause is not a disease, doesn't it at least cause disease? And so we've certainly seen graphs like this, which shows the rate per 100,000 persons of coronary artery disease, stroke, and so on, and showing this very large increase. However, the bracketed or the outlying ages are where menopause starts, and so certainly I'm not convinced based on this graph that menopause causes these conditions. We also know that if you compare women to men, and this was at a time when everybody was either a woman or a man, that's no longer the case, you'll see that women, surpass men as far as having heart attack or coronary artery disease, but not until they're in their 80s. So this is not convincing that when a woman's estrogen levels decline in her 50s or perhaps even earlier, that there's this epidemic of coronary artery disease and stroke. This is a similar sort of thing. And of course, what we're looking at is not effects of menopause. What we're looking at is effects of aging. Well, the problem with aging is we don't have any ability to control aging. And so what we have to do is convert aging, or at least these problems. If we make them due to menopause, we have pills for menopause. We don't have pills for aging. Let's talk a little bit about bones. This, I think you all recognize as a hip, and this shows osteoporotic fracture. Osteoporosis is a term for bone fragility per 1,000 women per year, showing an increase with age. Again, not starting really until advanced ages, well after the menopausal transition has occurred. What I found interesting was this slide, which is somewhat old, but it was certainly during the era when estrogen was widely promoted for health concerns. You'll see that white women had the highest rate of fracture per 100,000 women. Black men had the lowest rate at any given age. This is by age. But white men and black women were pretty nearly the same. So is it that black men, that black women don't become menopausal, or white men do become menopausal? Well, the answer is menopause is really not directly related to fracture. Fracture is related in part, but only in part, to how much calcium you have in your bones. So this is a bone densitometry scan or graph showing what happens to bone density with age. And you see that it sort of gently goes down, starting at about the age of 30. So those of you in the room who are older than 30, you're over the hill. The rest of you, stay tuned. We draw 2 standard deviations around that, and that's the dashed lines here. We define normal as the bone density at age 30, because that's at the peak. And then we look at 1 or 2 standard deviations or 2.5 standard deviations below that. And we define different, we give these benchmarks different names, so that some people will say that you have low bone density if you're 1 or 2 standard deviations below the mean for age 30. We used to call 2 standard deviations osteopenia, which is Greek for too few bones. That's actually, of course, not correct. You have the same number of bones. But we no longer say osteopenia because it's embarrassing, because it's not a real disease, it's a made-up disease. 2.5 standard deviations is called osteoporosis. Okay, maybe. But of course, bone density is only part of the issue. Bone architecture is at least as important, if not more so. So on the left, you have normal bone architecture. These are electron micrographs of bone, trabecular bone. And on the right, you have osteoporotic bone, and clearly you can see there's less bone. There's also crummy architecture. Here's my analogy. That's a stool, and good architecture means you have these little struts in there to keep the stool from collapsing. You can have the same bone density or wood density, if you will, by putting the struts that way. But which stool do you want to sit on? So bone density is not the only factor here. So for example, we have what used to be a medicine called sodium fluoride, which increases bone density, also increases fracture, because even though it's increasing bone density, it's not a friend of bone architecture. Anti-resorptive medicines, which are not estrogen, are effective in preventing the decline in bone density, and they decrease fracture in older women who have low bone density. But we don't know what they do in women with unmeasured bone density or in women with normal bone density. So this is a big market, one that I'm not here to talk about, but actually I'm going to talk a little bit about it. Here's an advertising piece for Resendronate, which is a bisphosphonate, showing the decrease as soon as 6 months after you start taking this drug in the percent of patients who have a reduction in vertebral fractures. So those can be painful. They're generally not that disabling, but this was used to sell this drug. You'll notice on the y-axis that we have a scale that starts at 0 and goes all the way up to 1.8%. So I redrew this graph on with a different y-axis. So here's what it looks like if you use 100. But why not give these drugs? Shouldn't they be in the water too? Because all of us, as we get older, are more prone to fracture, largely because we fall more. But that's a different story. In other words, if you take the loose rugs out of my house, I will fall less than if you leave them in there. And so there are some reasons not to use these drugs. Cost is one of them. Side effects. No surprise to this audience that all medicines have side effects. And of course, the way these drugs work, or at least the way some of them work, is by preventing resorption of bone by osteoclasts. Those are cells that eat away at the bone, so the osteoblasts, which put the bone back, and put it back better. And this is the way that bones that suffer little microtraumas can fix themselves. Preventing osteoclasts from working is not necessarily a good thing. Osteoclasts have been characterized as villains, but they're not villains. They're good cells because they're doing something important. So if you leave your bones unremodeled, that can't be very good for the bone. Hot flashes are certainly a big problem for some women for some period of time, not for all women, not forever. But I'm not here to talk about hot flashes because I don't have any personal experience with them. So some of you may have some personal experience. I'm just here to say that we have a lot of choices for interventions that can help with hot flashes, one of which is estrogen, but many of which are not estrogen. Well, why are we so susceptible to mythology? And the answer is clear. And so here's the market, which is somewhere in the range of $5 billion. This is the North American market. This is not the world market. So about $5 billion at stake in North America, and that's annually. So this is, it's not the biggest market, but it's pretty big. And this shows in 2018 what drugs contributed to this market. Bisphosphonates are the light blue portion, which is the largest portion. Hormone therapy is that green portion. So the hormone therapy and bisphosphonates make up probably almost 2/3 of the market. By the way, this slide says hormone replacement therapy. This book, sorry, Cindy, says the truth about hormone replacement therapy. Well, if you have juvenile onset or class 1 diabetes, you have missing hormone. You don't have insulin, so give insulin. That's hormone replacement therapy. But remember, estrogen concentrations in the blood of menopausal women are normal. There's nothing missing. And so giving estrogen and progestin or estrogen alone to a menopausal woman is not replacement. So the estrogen question, this is an old picture, is not, is it a natural supplement or a dangerous drug? The question is, does this woman need to take medicine? Or should we be spending our time talking to our patients about other health promoting factors? And could these people possibly be normal? And of course the answer is, yeah, of course they're normal. Thank you very much.